Hello, friends. Greetings to everyone. My name is Pawan Sharma, and I'm a pediatrician. Hope you all are doing well. Let us continue our journey through clinical pediatrics or a bedside pediatrics. I hope you will like it, and if you do, or if you do have any suggestions, comments, please do let us know in the comment box or through the link provided. I wish this could have been a live session, but hopefully in future. In this scenario, I'll bring up a couple of pictures, a query, and then towards the end, there is a quiz. So please do answer in the comment box, or you can directly email me as well. I will try to create a download link where you can download this PPT and a PDF file. Hopefully, that will be useful to you for your presentations and your learning. This is a real life case. When I was to work in a transport team, there was a girl with the Turner syndrome. She had a background of recent diagnosis of Crohn's disease, and she used to suffer from recurrent cellulitis and shingles, being followed by the infectious and immunology department. She attended clinic with a history of breathlessness, which was gradually increasing since about 3 weeks of time. Before I say anything, you can think about all different questions you're going to ask her. But there was no history of any fever. She had no edema, and she had seen the GP who has started her on amoxicillin for suspected chest infection. So one of our registrars saw her in the clinic and she thought that she was slightly tachypneic. Her heart rate was about 100 per minute. Blood pressure was not taken. With the possibility of chest infection, she had requested an X-ray chest, and this little girl was sent home, waiting for X-ray result to come back. Her history was quite typical of exertional dyspnea. What I would like you to do is think about various differential diagnoses or causes for exertional dyspnea, and we'll come back to that towards the end again. So later in the afternoon, when registrar had a time, she had a look at the X-ray, and this is what it looked like. Think about differential diagnosis for this thing, and then we'll come back again to talk about it. After we have seen the X-ray, this girl was called back again as expected, and this was done. So you can see the ECG. Think about two positive findings on this thing. Let's see whether you can spot it, and then we'll talk about it towards the end again. With a suspicion from X-ray and ECG, she had an echocardiogram, and it confirmed our diagnosis of pericardial effusion. We transferred her to the regional tertiary unit where she underwent pericardiocentesis, which is a tapping of fluid from the pericardium, which can be done as two things. One is therapeutic and diagnostic. She had a drainage of about 1.5 liters of fluid. Unfortunately, I do not know the final diagnosis. Okay, coming back to the first question, the causes of exertional dyspnea. Very typically, it is the cardiac conditions, heart failure, which causes exertional dyspnea, and it has been divided into four different grades depending on the severity. The respiratory causes is a little bit uncommon as an exertional dyspnea, but bronchial asthma is one which can typically present as exertional dyspnea. Okay, and then you have hematological conditions like severe anemia, significant polycythemia. And there may be more causes. Have a think about it, read about it. Okay, I'm pretty much sure that you all have diagnosed this as a massive or a large cardiomegaly. Think about the differential diagnosis. To mention some of them, or common of them, are congestive cardiac failure, pericardial effusion, Epstein's anomaly is an interesting pathology, so do read about it, and cardiomyopathies. Have you spotted two positive findings from this ECG? Okay, so I'm sure you probably would have, but let me tell you that one is there are low voltage complexes. Number two is electrical alternans, where you can see that the QRS complexes. If you see the last one, the lead 2, V1, and V5, you can see that. And then the QRS complexes are small at places and large at places. So this is one of the findings you see in the pericardial effusion. Now think about various causes of low voltage complexes and the other causes of electrical alternance. I'll stop it here with a quiz. Okay, what is the most common cause of cardiac tamponade in a neonate? Okay, the other thing is, I'm sorry, I have not included details about the pericardial effusion, but I'll definitely make a separate video only on pericardial effusion, discussing the causes, the pathophysiology, and the management. Hopefully, that will be useful to you guys as well. Please do not hesitate to message about the quiz. If you do have any query, comments, either way, positive and negative, please let us know. Thank you so much.